Okay, so this is our next lecture. This is a talk on sort of miscellaneous demyelinating and inflammatory disorders that I think are of the highest yield. So let's start out with a comparative case. And this is very useful. We've got two post-contrast T1 images here, and we've got two things that are enhancing. Got this guy here, got that guy there. And what I want to point out is the pattern of enhancement, because this is very helpful for eliminating distractors on multiple choice. So when you see a case that's got an enhancing lesion, I want you to sort of categorize it as either an incomplete ring or a complete ring. And that's really helpful, because when you see that incomplete ring, you know you're dealing with a demyelinating lesion. Now, there's a bunch of different kinds of demyelinating stuff, and we're going to talk about that in this talk. But if they're going to show you demyelination on multiple choice, it's different in the real world, because real world lots of stuff can happen. But in the multiple choice world, you have to think like a Sith. You know, Siths deal in absolutes. So you have to think, okay, boom, boom. We're going with Aunt Minnie stuff here. Okay, now ring pattern, that can be a whole bunch of stuff. There's a big differential for that. Magic Doctor is the one that Branton Helms uses. You may have another one that you use, but basically, tumors, hematomas, infections, lots of stuff that enhances in the head that's not demyelination. So here's an example. We've got a ring enhancing lesion, right? Boom. And then I'm showing you diffusion. See, this is another sort of stratagem that can be used in multiple choice for these kinds of cases. You got to have a list in your head of the things that restrict and the things that don't restrict. And I'll repeat this throughout all these neurotalks. You get sick of hearing me say it, but I want you should be able to do this. So when you see a diffusion case, showing you that for a reason. It's to help you eliminate distractors. You don't have to actually know what it is sometimes on multiple choice. If you got 4 choices, you can eliminate 3 of them, then you know it's the other one. So in your head, you should have a list of stuff that restricts. So stroke restricts, certain infections restrict, and a bunch of hypercellular tumors restrict. Which ones? Classic ones: lymphoma, GBM, and medulloblastoma that are hypercellular can do it too. For the purpose of multiple choice, it's lymphoma. Acute demyelinating lesions can restrict diffusion. So, like, remember MS plaques, when they're acute, they can restrict diffusion. Certain infections like herpes encephalitis classically will restrict diffusion. CJD can restrict diffusion. Then you can have fake outs like T2 shine through, those kinds of things too. So get that list together in your head. It's listed in my books. You can find one online if you don't have one right away. So this is a case where the thing is not restricting diffusion. So remember I said certain infections? So not all infections. Classically, bacterial infections restrict diffusion. Atypical infections like this is actually a case of toxo, does not restrict. So going back to this again, incomplete rings, remember we said those are demyelinating. And then when you've got ring pattern, like the full circle of enhancement, think about things that restrict or things that don't restrict. So things that typically don't restrict: atypical infections, toxo is the one you need to remember, METs. Things that do restrict: hypercellular tumors, GBM or lymphoma, or typical infections like bacterial abscess. So if you just remember this right here, okay, show me enhancement, ring or not ring, showing me diffusion, restricts or doesn't restrict. Very helpful for eliminating distractors. And we talk about this in the tumor lecture too, but you can tell GBM and lymphoma apart by their enhancement patterns as well, because lymphoma tends to enhance homogeneously, just like it does everywhere else in the body, whereas GBMs are these multiforme, right? So they're a big heterogeneous mess of shit that enhances in sort of an aggressive but heterogeneous pattern. All right, so classic case, can't forget about this. This is the way that it's going to be shown classically, because we're showing these demyelinating lesions along the callosal septal junction. Some people will call these things Dawson fingers, right? These little guys right here. And then we've got sort of a whole bunch of different ones separated in time and space, right? MS. So the thing to remember is involvement of the callosal septal interface, 98% specific. It's unusual to see plaques infratentorial unless you're dealing with childhood form. Of course, they tend to be multiple, and remember that when they're acute, they tend to have restricted diffusion and enhancement. So this is what you hear. You hear this from neurologists, if they know anything, but you will hear neurologists say separation in time and space, and what that means to a radiologist is different locations, and then time. In other words, you've got acute plaques and you've got chronic plaques. Few things that are testable with regard to trivia. There is a relationship with EBV, Epstein-Barr virus. It's actually rare to have MS and be EBV negative. There's a sunlight thing. It's actually rare the closer you are to the equator, so more sunlight is protective, less sunlight is somehow high risk. There's a very controversial thing about venous outflow. There's been some people that have tried putting stents in people's venous structures in the CNS system that they think is somehow related to MS, and they can correct MS. There's at least one lawsuit where one of those things like migrates and kills somebody. It's very bad, especially when you're killing young people and you're doing controversial stuff. So I don't think that'll be show up on the test. White people, way more common, European descent, and it's female, right? So young, female, separation in time and space, rare underneath the tentorium, outside of a kid, enhancement and restricted diffusion, incomplete ring sign. All right, so what about some stuff that looks like MS, but it's not MS? Two basic categories on that. Vasculitis tends to favor the basal ganglia. It tends to spare the callosal septal interface. That's why I pointed that out earlier. Lyme's, man, that Lyme's can really look like MS, but tends to have more cranial nerve stuff. If I was going to show you Lyme's, I would show you cranial nerve enhancement. That's the way that I would show it, and or just sort of knowing that it's in the differential. It's probably the thing you need to know. All right, so moving on. Here's another case. So, all right, so let's go through these. This is a really important skill. I'm going to do this repeatedly throughout all these neuro lectures. You'll get sick of me doing it, but it's super important that you do it. You cannot give up points on this stuff. So let's figure out what these are. All right, so this guy here. All right, so CSF is dark. Two things have that, T1 and flare. White matter is white on T1. White matter is dark here, so that's flare. Let's do this next one here. White matter, we said that's white, so this is T1, and then T1 postcon anytime you're seeing contrast. So rule number one, if you've got enhancement, look at the pattern. What's the pattern of enhancement here? It's a ring, or it's incomplete ring, right? So we know that we're dealing with a demyelinating thing. A lot of edema, and it's big. So ADEM, it's monophasic for the purpose of multiple choice. Yes, you can have multiphasic types. If you'll read about that in book, don't get it twisted. They're usually monophasic, and just remember it like that. It's typically a childhood thing after vaccination, so vaccinations may not give you autism, but they can give you ADEM. It's large, so that's what you need to remember about this. Basically, it's big, and it's going to have a ring or incomplete ring pattern of enhancement, a lot of edema. So big, lots of edema, big ring in a kid. Think about this one. So it's actually common. It's a second only to MS as far as acquired demyelinating disorders. It does not have a female predilection. Remember that we said that MS does. Most of the time they recover completely, but sometimes they die. All right, next case. Another demyelinating thing. There's nothing on this specifically that would tell you that it was demyelinating other than the fact that we're talking about demyelinating stuff. Now, a couple of things I want to point out here. One is, you see the signal in the cord? Look how long segment that is, okay? So MS tends to be short segment. What do I mean by short segment? I mean like one vertebral body level. This is the long segment. So this in itself could be lots of stuff. This could be ischemia. That's a good spot for cord infarct in the history of a stent graft or something like that. It could be a few things, but then if you're showing you this picture right here where they want you to look at the optic nerves, there's only a few things that is, and this is definitely one of them. So, demyelinating disorder involving the optic nerve, long segment in the cord. All right, that's Devick's disease or neuromyelitis optica. Remember, you got to know both names on these things. Anytime you're learning this stuff, you got to know both names. Why do you got to know both names? Because if you only remember one name, more than likely when you take the test, they'll ask you the other name, and you won't know it. So you got to know both names. Cervical cord is the most common spot. Like I said, it's usually long segment, and it tends to, because it's a transverse myelitis, involve more than 2/3 of the cord. And we'll talk about that more in the spine lecture. Okay, so next case here. We've got what do we have? Let's figure it out. So CSF is dark. Two things do that, right? T1 and flare, but the white matter's white, so this is T1. So this is our classic T1 bright basal ganglia case. There's 4 things that you need to know that do that. If you can only remember one of them, I would remember liver failure. If you can only remember 2 of them, I would remember hyperal or manganese for it. That's probably the most likely, sort of in descending order as I've got them color-coded here. It's best to remember all 4. It's not that many. Liver failure for sure, though. So it's like hepatic encephalopathy kind of deal, not just like a little bit of liver. Like this is the brain stuff. All right, next case. This is something you probably have seen on call. We've got vasogenic edema, right? Vasogenic edema is the kind that sort of preserves that white matter thing, like the little claws that come around here. It's involving those U fibers, the ones that are U-shaped. And now I'm showing you that it's not restricting. So remember, this is a gamesmanship. So you can have things in the differential. You look at your A, B, C, D, and you say, okay, well, what restricts? A stroke restricts, right? This could be a stroke. Certain infections restrict. So things that don't, things that classically restrict, then you can eliminate, and then whatever's left, you could try to figure it out. So this is press. The main differential for press is actually a stroke. So you would want to see diffusion if you were looking at this in the real world. Remember the classic history: pregnancy, chemotherapy, or hypertension. If you're going to remember one of those, I would remember hypertension. It's not always posterior, but likely will be on the test. It's not always bilateral, but it will be on the test, and tends to be a little bit asymmetric. All right, next case. This is so centered in the pons. We do have some restricted diffusion here, and this is something that a lot of people don't think about when they learn about this, but it does actually restrict diffusion. But more than the usefulness of that is the location, right? It's central. It's in the pons, so it's central pontine myelinolysis. So CPM they call it. This is a person who is severely hyponatremic and then rapidly corrected. I have a funny story about this that I'll try to tell rapidly. I know the guy who wrote the original paper on CPM in the New England Journal of Medicine, and he said that when he originally wrote this up, that it got rejected, and then he resubmitted it, and then it got rejected again, and then apparently this is back in a time where you can argue with them. So he was like, no, seriously, this needs to be published. This is important. So they published it. Well, they published it on one page, and then on the next page, they published another paper saying that CPM was occurring because you weren't correcting the sodium fast enough. So apparently that was the reason they were rejecting, because there was 2 papers, one saying one and one saying the exact opposite. And as he told the story, he goes, I later would testify against him in court. So remember that it's when you're correcting the sodium too rapidly, and if you did, remember from med school or you were forced to do a medicine internship or transition year where you did any of this, remember there's a calculation for how fast you can correct the sodium. But anyway, if you fuck that up, this is what ends up happening: central pontine myelinolysis. So, oh yeah, one more thing, yeah. The diffusion helps you distinguish it from press, but I don't think that's necessary. The location gives it away. All right, next case. So this is a classic thing. You need to know this. So right here, this right here, central thalamus too on flare. So, but the most specific thing, or the most useful thing that they can show, is actually this case right here. So got a nice zoom in right here. So strong uniform enhancement of the mammillary bodies is seen in up to 80% of the cases and considered pathognomonic. So this is Wernicke's, bilateral medial thalamus, periaqueductal gray, and mammillary body enhancement. Remember, this is a thiamine deficiency, and this is why they give banana bags to everybody that comes in that's a drunk. So what else can involve the medial thalamus like this? I'll talk about this in the vascular section, but I'll bring it up again. Artery percheron and internal cerebral vein thrombosis. Artery percheron infarcts do not affect the mammillary bodies. What's the artery percheron? Watch the vascular lecture. All right, next case. All right, so we've got high signal crossing the corpus callosum. There's only a few things that do this. Demyelinating things can do this. Lymphoma is the classic tumor that does this. So this is seen in drunks, Marchiophila bignami. I think about it sort of as the mustache on the drunk Italian guy, and it's got a really classic look. It tends to be, quote, sandwiched, or it spares the most dorsal and ventral fibers and favors the central ones. Don't think you need to know that. Just know a high signal crossing the corpus callosum in a guy who likes to drink red wine. All right, next case. This is a classic look too. So low signal bilateral, right? And then high signal bilateral in T2. So this is carbon monoxide poisoning. The way to remember that is global warming, if you believe in that, which I don't, of course. Global warming, globus pallidus, global warming, carbon monoxide, which is actually a carbon dioxide problem, right? But whatever, warming, global warming, globus pallidus, that's how I remember it. So that's what it looks like. That's what it affects. All right, that's the end of the talk, and the next lecture will be my brain tumor talk.